Enterocutaneous fistula. So in this video, we'll be talking about the definition of enterocutaneous fistula, its causes, and the reasons for spontaneous closure of the enterocutaneous fistula, and finally, the management, the principles of management of the enterocutaneous fistula. Starting with the definition, the entero stands for intestine and cutaneous stands for skin. And the fistula, it is the abnormal connections. So the abnormal connections between the small intestine and the skin is what we call as the enterocutaneous fistula. And talking about the causes of enterocutaneous fistula includes the Crohn's disease, radiotherapy, abdominal trauma, surgical complications, that is, after anastomosis of two ends of the intestine, if there is a leak, or inadvertent enterotomy during the dissections, and during the appendectomy, during the gangrenous appendix is being removed, if there is inadvertent enterotomy, then it may also lead to the formation of enterocutaneous fistula. The other reason I is the malignancy and ileocecal tuberculosis. So these are the causes for enterocutaneous fistula. So one important thing is, so more proximal the fistula is located, there is more chance of severity of fluid and electrolyte imbalance in case of enterocutaneous fistula. So there is a term called high fistula output. If the content of the enterocutaneous fistula is more than 500 ml per day, then it is what we call as the high fistula output. Talking about the management, majority of the fistula, they can be expected to heal spontaneously. This enterocutaneous fistula, they heal spontaneously, but there should not be any distal obstructions or disease at the fistula site. But there are few regions which are responsible for failure of spontaneous healing of the enterocutaneous fistula. And there is a mnemonics for this. So the acronym is the FRIENDS, where F stands for foreign body in the fistula tract. R stands for radiation interiorities. I, inflammatory bowel disease like Crohn's disease. E, epithelialization of the tract. N, neoplasm. And if there is any distal obstructions, and sepsis. So it can be remembered as an acronym FRIENDS. So these are the reasons for failure of spontaneous healing of fistula. So now talking about the management of fistula, so there is a principle, famous principle, and this is usually asked in exams, principles of management of enterocutaneous fistula, and it has got a well-established acronym as the SNAP. So what does SNAP says? So S stands for elimination of sepsis and skin protection, where N stands for nutrition, whether to provide parenteral nutrition or enteral nutrition to the patients. It needs to be decided. And A stands for anatomical assessment and P stands for definitive planned surgery. So to look upon this on detail, so sepsis. So if there is any collections, infected collections, first it needs to be seen by the CT scan. Here in this picture we can see CT scan of complex enterocutaneous fistula is done, and here the abscess is formed which is being drained with CT guided catheter. So for management of sepsis, first if there is collection or not needs to be seen, and if there is collection, that needs to be drained, the CT guided, and after that proper antibiotics needs to be given to the patients. Since the effluent content is caustic, so it excoriates the skin. So for management of excoriations, we can apply the zinc oxide cream. So and for N, So N stands for nutritions. So nutritional support must include the fluid and electrolytes, especially in the high output fistula, because in high output fistula, high quantities from the proximal fistula, fluids and electrolytes are being lost. So fluid and electrolyte balance needs to be done. Other than fluid and electrolyte, other nutritional requirements like carbohydrates, proteins, fats, and vitamins needs also to be provided. And whether to provide enteral feeding or parenteral feeding, that needs to be judged. Enteral feeding has advantage, but if the fistula is proximal or high output, total parenteral nutritions will be required. And after that, A stands for defining anatomy. So what is the anatomy of the intestine? So it needs to be assessed by different investigations after discussion with the radiologist, like a sequence of contrast studies like follow 3 or fistulogram. It might be fistulogram using the gastrographin, or CT scan and CT guided fistulogram needs to be done. And barium enema, it helps to define the bowel length. So after defining the anatomy, we'll go for the P, planned surgery, that is definitive planned surgery, where if the fistula persists, then the fistula needs to be explored and resection needs to be done. Resection of the fistula needs to be done. After that, the underlying cause, that the causes that we have discussed before, it needs to be treated. After that, if bypass is required, it needs to be done. So yes, so we have read about the definition. So enterocutaneous fistula. So enterocutaneous fistula is the abnormal connections. It is the abnormal connections between the skin and the intestine. After that, we have read about the causes. Causes like inflammatory bowel disease like Crohn's disease. It might be because of the radiations, because of the neoplasm or abdominal trauma, surgical complications. So these are the causes, and we have read about the factors that are responsible in reasons for spontaneous healing of enterocutaneous fistula, and we have an acronym like FRIENDS, and finally the management, the famous SNAP protocol, where S stands for the managing the sepsis, and skin exfoliation management, and for the nutrition, A for defining anatomy, and P for the planned surgery. So here in this picture we can see, so this is the enterocutaneous fistula,